So the title of our session today is Mapping the Participant Journey, Disability Inclusion in the Research Process. Again, my name is Paula Moody. I sit on the chair, I am a member of the program called CHEER, which is Community Health Equity and Engagement in Research. I'm joined by my colleague Jennifer Poger today, who is the Director of Program and Education. And our colleague Jess Schrodel is also a research project manager. Unfortunately, she wasn't able to join us. She's out and about doing some community engagement activities today, but she is also a member of the CHEER team, so we certainly want to acknowledge her. One of the things that we do under the CHEER initiative is offer educational sessions like this one to advance health equity and to minimize health disparities in the research spectrum. And one of the topics that we want to cover among many is disability access in research participation. I have the distinct pleasure of welcoming our guest presenter today, Willyanne DeCormier Plosky. I'll share a little bit about Willyanne. I had the chance to see her present in a different session and was absolutely really just incredibly impressed by the content that she was sharing during that session. So I'm so grateful to her that she was willing to share some of her insight and expertise with those of you on the call today. I'll provide you a bit about Willyanne from her professional accolades. Willyanne is the program director at the Multi-Regional Clinical Trial Center of Brigham and Women's Hospital in Harvard, where she leads the diversity, equity, and inclusion in clinical research portfolio. Previously, she spent more than 15 years working for Management Sciences for Health, the World Bank, Avenir Health, UNICEF, and USAID in the areas of health economics, maternal and child health, disability rights, HIV/AIDS, and humanitarian response. She participated in the Global Health Cost Consortium as a core team member, collaborated on the development of the first U.S. government action plan on children in adversity, and supported the improvement of cost-effectiveness modeling of HIV and malaria interventions. She has also served for 5 years on the board of directors for All Farmers, an organization that supports refugee and immigrant families to access arable urban land and farmers markets. Dr. DeCormier Plosky earned her DrPH in Global Health Leadership and Humanitarian Assistance from the Columbia University Mailman School of Public Health, received her MPH in Global Health from the Yale University School of Public Health, and her BA in African History and Anthropology from Bowdoin College. I'm pleased to welcome her today and her expertise on this topic. We'll cover a few kind of housekeeping things before Willyanne begins her presentation. You may have noticed already, thank you, Jen, that our presentation is being recorded. We do this because CHEER as a group offers a platform, an educational platform where we keep our sessions recorded for future access, in case you want to share this with other folks who maybe could not attend today. If you have questions, we encourage you to utilize the chat. There will be a Q&A session at the end of the presentation, so we would ask you to please hold your questions until that point where you could utilize the chat or raise your hand to do that. Information will be shared with participants following today's session, which will include the slide deck, and we'll also ask you to complete a survey, so an evaluation at the end of this session. If you don't have the chance to complete that today, the link will also be provided with the follow-up materials. Today's agenda includes some of these things listed, well, all of these things listed here, I should say. These are the topics that Willyanne will be covering in her session: disability, ableism, and the differences between equity, equality, and justice. some key points about disability law, a review for a toolkit called Accessibility by Design, capacity, accessibility, and finances, and how those play a role in research participation and how research teams can take these into consideration. And then finally, Willyanne will be conducting an exercise with all of you called Mapping the Participant Journey. Finally, we'll close out with a Q&A session and any other wrap-up questions and comments. So without further ado, I'm going to turn this session over to Willyanne and thank her again for her expertise.
Good morning, everyone. Many thanks to the CHEER program and to Penn State for the invitation to be here. And thank you, Paula, for such a lovely introduction. And I just want to say thank you to everyone who's attending for taking time out to attend, and you'll see to participate in this panel as we go forward throughout the session. So my name is Willyanne. I have brown hair and brown eyes. I'm currently wearing glasses, and I have on a blue kind of flowered shirt with blue and black flowers. It's a little bit about me. You can go on to the next slide, please. So just our standard disclaimer that the materials and opinions expressed here are my own and not intended to represent Mass General, Brigham, or Harvard. The MRCT Center is supported by volunteer contributions, and our work is licensed under a Creative Commons license. Next slide, please. So for those who don't know the MRCT Center, we are a multidisciplinary center that's based at Brigham and Women's and Harvard. So what we do is we basically collaborate across all of clinical research, whether it's large research institutions, small research institutions, sites, CROs, lots of sponsors. We work with the NIH and the FDA. And what we do is we try and understand what are the big challenges in clinical research and how can we work collaboratively to address them. And we try and basically develop tools, or we do things like we write in on, response to public comments and things like that to try and, create a consensus and help move the work forward. Next slide, please. So to give you a little bit of background about disability, there are about 1 billion people and 240 million children globally who have a disability. People with disabilities are actually the largest minority group in the United States. So about 1 in 4 adults lives with a disability. And that percentage is actually higher in racial minority communities. So about 1 in 3 people who are Black or African American and 1 in 3 people who are Hispanic have a disability. So as many of you know who are involved in research, the FDA now requires diversity action plans for phase 3 and later trials. The guidance from the FDA focuses on race and ethnicity, but it does mention disability. And I kind of also add my personal note that, if we're thinking about setting goals for diversity, as the FDA recommends along racial and ethnic lines, I personally feel that we're not going to be able to meet those goals unless we address disability and accessibility, because the populations who have disabilities are greater within minority communities. Just to note that there's many kinds of disabilities. You can have visual disabilities, hearing, mobility. You can have chronic conditions. I personally have severe asthma. So you'll hear me sort of, sometimes it's difficult to talk. So if I'm drinking tea, it's just part of that. Mental health, cognitive and intellectual disabilities or developmental disabilities. And I also wanted to note just that mental health and cognitive or developmental disabilities are not the same. People may have both, but they're different kind of categories of disability. Next slide, please. So I just wanted to take a second to talk a little bit about ableism, and I'm just going to go from the first bullet point that you see on your slide. So ableism is defined as a network of beliefs, processes, and practices that produce a particular kind of self and body, the corporeal standard that is projected as the perfect, species typical, and therefore essential and fully human. And I just want to come back to this corporeal standard that people without disabilities are often assumed to be the ideal, and people with disabilities are less than ideal. under ableist assumptions. Next slide, please. So I just want to note how that sort of impacts people with disabilities throughout the clinical care and clinical research process. So this is just a little bit of data from the Health Affairs Special Issue on Disability and Health that came out in 2023, I believe. So they surveyed physicians, they surveyed over 700 physicians. Over 80% assumed that people with significant disability have a worse quality of life than people without disability. And they had a number of quotes that they drew from doctors. And one of them said, "I am not the doctor for you," which is kind of a common, they showed that this was a common response across the doctors, that even in trying to just access clinical care, people with disabilities found that there are many barriers because physicians did not want to treat them. They didn't know how and didn't want to. Next slide, please. So then in trying to take the next step, if you're a person with a disability trying to become a clinical care provider, only about 3% of surveyed physicians self-identify as having a disability. And within that 3%, only 9% of that 3% identify as members of underrepresented racial groups. So it's something like 16 out of the 6,000 people have a disability and are from a minority racial group. So I wanted to point people to this link on the slide called Docs with Disabilities. It's an initiative led by Lisa Meeks, and she has some great data and tools and kind of supporting people with disabilities to become clinical providers. Next slide, please. So extending that just one more step to the clinical research space, because many people in clinical research come from a medical background. It's difficult sometimes to break into clinical research as a researcher if you don't have an MD. So just to show you some statistics, currently, or at least in 2018, only about 1% of people who submitted NIH grant applications, who are principal investigators, self-reported having a disability, 1%. And this is with the data that I showed you before, that 1 in 4 adults have a disability. So that's markedly different than the population in the United States. It's also declining from 2008, where we saw that that was about 2% of people self-reported a disability. So there's definitely something going on between, even the population size and those that are able to become a clinical provider and a clinical researcher. So likely lots due to ableism. Next slide, please. So I thought this slide is a good sort of representation of where the disability community is trying to advocate. So on the left-hand side, you see a picture where we talk about equality. And equality is considered where everyone gets the same support. So you can see that you have a tall person and then a child and then a person who uses a wheelchair, and they're trying to look over a fence to see a soccer game. They all get the same support in that a box is put in front of the fence, but it really only works for the person who's taller. The person who's a little bit, smaller still has some difficulty seeing over, and the person who uses a wheelchair can't use that type of support. When we talk about equity on the right-hand side, you can see that the person who's smaller has 2 boxes given to them, and the person who uses a wheelchair has a ramp that allows them to see over. And we say that equity is where everyone gets the support that they need. So you can see the distinction there. And then I don't have it on the slide, but really what the disability rights community is advocating for is to move towards justice, which is really when we talk about systemic level supports. So really kind of what are the systemic barriers and what are the systemic supports that need to be in place. Next slide, please. So when we talk about accessibility and making sure that people who have disabilities are included in clinical research, it's not only, a good thing to do and an ethical thing to do, but it is the law. So I often try and point that out, that under the Americans with Disabilities Act and Section 504 of the Rehabilitation Act, and also Section 1557 of the Affordable Care Act, discrimination against people with disabilities is illegal. And I really think that unfortunately, I don't have the link in here, but the updated rule for Section 504 of the Rehabilitation Act came out in June. It's really an important read. There's a lot of really good information in there about making sure that everything is accessible for people with disabilities. And also the 1557 revised rule also came out, I think, at the end of June. So they're both really good to have kind of a refresh of your memory of what's in there. In terms of state laws, these can vary. So it's often good, I'm sure many of you know, to be checking kind of your state law when you're talking to your legal departments as much as the federal laws. So state law variations are particularly, I think, important around working with people with cognitive and intellectual disabilities. And when we have supports such as supported decision-making, those can really vary by state in terms of how those are applied. Under clinical research guidelines, you can look to the Department of Health and Human Services and the Protection of Human Research Subjects, and also the SAC-HARP Secretary's Advisory Committee on Human Research Protections. And lastly, I just wanted to point to the Harvard Law Project I just love them to death. Like, they have such a great set of resources on inclusion of people with disabilities, and it's not specific to healthcare or clinical research, but some of the things that they do, they put in real plain language. Like, there's a document called We Have Human Rights, and it just really spells out so clearly a lot of the things that I'm talking about in just a very easy to read format. And I find myself, I'm always drawn to things that are in plain language because it just makes it much easier to digest. Next slide, please. So one of the things that I'm going to talk a little bit about is the Accessibility by Design in Clinical Research Toolkit. I put the link on the slide, and I'm also going to just put it in the chat for you guys. So there's a QR code there. I put the link in the chat. I'm going to go on to the next slide, Paula. So a couple of years ago, when we started working on this project, we realized that there wasn't really a lot of comprehensive tools for clinical research for accessibility. There were some tools that were in the education space, and you're at a university. So there were some like really around education or around communication, like website development and things like that. But there weren't really a lot of specific tools for clinical research. So we put together this toolkit that goes through 5 different themes. And the first one is around general considerations for working with people with disabilities. The second is around communication accessibility. The third one is physical accessibility. And the fourth is newer strategies for inclusion. So I mentioned supported decision-making before. That's among the newer strategies. It's not really new in the disability community or even new in clinical care, right? Most people want to bring someone with them, to help them make decisions. But it's new in terms of like working through IRBs and kind of getting this more formalized within the clinical research space. And then the last part is called upholding accessibility through accountability and advocacy. And it gives a lot of kind of advocacy points if you're trying to advocate within your organization or for, for policy, some key points. And there's actually some business points in there as well for those of us, I've learned from a long time working in healthcare that if you don't have an economic argument, it's hard to kind of make progress. So I always tell people, think about your iPhone or your Mac. Why is that so popular? Why is that, so great for you to use? And it's because it's really accessible. It's, the apps are all easy to use. It's intuitive. You can make it larger or smaller. Those companies worked closely with people with disabilities, and their products are a success because of it. So just to think about in your own life, the products that you like to use. Texting, for example, was developed with people with disabilities. So the things that you find the most useful, others will too. So next slide, please. So just to show you a snapshot from the Accessibility by Design Toolkit, it's organized by within those 5 themes by 2 sections. One is on key points within each of those themes, and then I'll show you some tools in a second. But the key points, we organize them by green, sort of like skiing or adaptive skiing, by green circle is easy, blue square is moderate, and black diamond is not, super hard, but it's more advanced. It can require some more coordination or more advanced knowledge, specifically in legal or technology like programming. But you can see the first few things are super easy. Don't assume, just ask, practice active listening, respect autonomy and speak directly to the individual, treat physical aids as an individual's personal space, things like using larger font and contrasting colors. And this is one I often bring up, refrain from animation in PowerPoints because, flashing and spinning things can be difficult for people with sensory disabilities. So if you must use animation, you can use like an appear function. But anyway, lots of it. The main takeaway is that many accommodations are low or no cost and are fairly easy to do. Next slide, please. So here's just a few tools that are specific to clinical research. One of them is on the eligibility criteria. And we did a study that I'll show you, I think it's in the series, looking at eligibility criteria. And we found that many, many people with disabilities were excluded because of the language used in eligibility criteria. The main takeaway is to make sure that eligibility criteria, when people are excluded, that needs to be justified clearly for safety or for scientific reasons. And by scientific reason, we mean you can't just put in a bucket thing that says, because they may impact study results, or they may, not be able to finish the trial. Specifically, you have to say what the exclusions are. We're excluding people with visual disabilities because X safety reason or X scientific reason. Next slide, please. So another place that we put in the toolkit is around outcome measures. So often people with disabilities are excluded because of the outcome measures that are utilized, that there isn't any adaptation for outcome measure that can be used by people with disabilities. So I put in the example here, for example, for the endpoint that they're wanting to measure is physical fitness. The study is doing that through a measure of walking speed, and the methodology is a 6-minute walk test. But really, the study needs to ask, is this accessible to all people in the study? And can we have adaptations here? So people, for example, who use a cane or who use a wheelchair might have differences in how they can use this outcome measure. Maybe you can change the measure for people who use a wheelchair to something like, physical fitness using their arms, or even something like tongue pressure is now being shown to be an adequate measure actually of physical fitness. So which people can use actually just sitting down who have quadriplegia. So just to always think about what the outcome measures are that are being asked for in the trial. Next slide, please. Okay, I'm going to go one more because I talked about eligibility criteria already. So just to say, in our study that we did, we found that people with psychiatric disabilities were excluded in close to 70% of trials that we reviewed, and people with visual disabilities about 34% of trials. And just to say, within specific disease areas, this really varies. So even while people with cognitive and intellectual disabilities were excluded in 42% of reviewed studies, in studies of dementia, they were excluded in over 90% of studies. And this is really problematic because the people who need that kind of research are being excluded from the research. So for example, people with Down syndrome who develop early onset Alzheimer's are being routinely excluded from trials of Alzheimer's and dementia. And we found that only 24% of the exclusions had a listed justification. And as I said, many of these justifications were very broad. They would say it's the investigator discretion, or the person is unlikely to complete the trial. The person is unreliable. Many of these kinds of very broad criteria. So next slide, please. So just to say, to conclude before we go into the exercise, a couple of current areas of discussion. So you'll notice that the Accessibility by Design Toolkit does not get very far into discussing capacity assessment around cognitive and intellectual disabilities. There are some other really good sources out there, which are in the toolkit. But just to say, we're going to be trying to add a little bit more information to the toolkit in the future around working with people with cognitive and intellectual disabilities, and sort of this, often there's a bit of a gray area between lacks capacity and has capacity. There's an area of people who have reduced or limited capacity, but still can make autonomous decisions. So there's a lot of researchers who ask us questions, how do we sort of navigate within this space? One of the resources on the screen is called Accessible Research Ethics for All. This is a great initiative. Colleagues from Syracuse and UNH developed this for people who have cognitive and intellectual disabilities who want to be researchers as part of the research team. And I find their tools just to be fantastic. They developed some like informed consent forms that are just very good, plain language, straightforward informed consent forms. And they do that by having people with cognitive and intellectual disabilities as part of the team that help develop these resources. Next slide, please. Okay, and just to say, a couple of the other areas that we've been talking about is decentralized trials. So often decentralized trials, we hear kind of, there's many wonderful things about decentralized trials, but they're often taken to be, in a way, a panacea for accessibility. You know, we're broadening out trials, bringing them closer to people, bringing them into people's homes. But we often have to question, are these really accessible, especially for people with disabilities? When you have, for example, you're accessing things through an app, through multiple, you know, a laptop, a watch, you've got to be able to navigate all of that. You have people coming into your home, which may or may not be something that you feel comfortable with. And do those people have the skills to be able to work with people, for example, with physical disabilities, to, you know, to be able to, if you need to be moved or something, you know, or examined in a way that's comfortable for you. And also issues around financial accessibility. And this was brought up in the recent 504, but also I think it was the Department of Justice was revising their rule on accessible medical equipment and saying, okay, if you don't have accessible medical equipment at your facility, you can maybe send people to another facility where there's accessible medical equipment, such as accessible mammograms or MRIs. However, that means that the person with a disability has to travel a greater distance, and that can cause, you know, some financial, always the financial accessibility piece is most often about travel costs. So just to keep in mind, it's understandable that large medical equipment isn't going to be available everywhere, but just, you know, to keep in mind that there may need to be additional accommodations as far as travel reimbursement. Next slide, please. So lastly, just a few things on disability data. You know, we always say you can't be seen if you're not counted. And so this has been shown in a number of areas. Disability data is still not really collected in clinical trials. And there's a lot of debate even across the US government and internationally about what the disability kind of standard data collection should be. So I put a few resources on the slide. And just lastly, talking a little bit more about financial neutrality for participants with disabilities. Some of the things we've been talking about are not only the travel costs, but things like the tax law, which requires, you know, I think there's a carve out of $2,000 for people with rare diseases, but that hasn't been extended yet past people with rare disease. So if you are compensated for participating in the trial for your time, that can go on that's a tax liability, and people can lose their benefits if they earn more than even something like $500 a month in some states. So it's just something that I think is working its way. There's a couple of bills working their way through Congress, but until those are actually a reality, the tax law is really important for people with disabilities. Next slide, please. Okay, so we're going to go through a little exercise. Hopefully this will be fun. We're going to talk a little bit about mapping the participant journey. I want, next slide, please. So we're going to talk about both physical and virtual site accessibility. This trial journey, not only for the participant, but also for family members and supporters. The journey involves, as many of you know, getting from home to the parking lot or the bus stop to into the building and around the building. It's very important to plan for this journey with people with disabilities. And what we're doing here does not really replace sort of, making sure that you engage with people with disabilities to do this kind of planning. Next slide, please. So what we're going to do, we're going to look at each slide. I'm going to give you about a minute to look at the slide and to write in the chat where you see that from your perspective, where there might be challenges for people with disabilities. And these challenges can be from different disability perspectives. So I put on here, I just want you to keep this in the back of your mind. It can be a visual disability, a hearing disability, mobility disability, a sensory, so things like, bright lights, flashing, noise, crowds, all those kinds of things, smells, or a cognitive and intellectual disability. You can comment on any of those things in the coming slides. So let's get started. Next slide, please. Okay, so we're going to talk about fixed sites first. On the left-hand side, you see sort of a map from the site to the facility. By car, it's 18 minutes. By multiple buses or bus and train, it's 1 hour and 20 minutes. So I'd just like you to look at the slide for about 30 seconds, and then you can start writing in the chat things that you think might be challenging for people with disabilities. Great, so I see some great responses. Things about financial accessibility that can cost more sometimes, depending on which mode of transportation you take. The mental burden of having to take multiple buses and trains to get somewhere if you do not have a car. You can see on the screen that I just think it's a really ironic picture because the bus has a symbol of somebody who uses a wheelchair, but you can't actually get on that bus because it's so crowded, which I find all the time when I'm in New York or Boston that I can't actually get on a bus. Taking time out of work, it's extra time out of work, out of childcare, all of these things, very important. All right, great. So let's go on to the next slide. So I used our own lovely institution at Mass General to show you the front of a facility. So you can see on the screen, we're showing the front of Mass General Brigham, the entrances, and there are an ambulance coming by and people on the street who are trying to walk across a crosswalk. So I'm also going to give you about 30 seconds to look at this picture and just chime in with anything that you think might be problematic. Okay, I love all of these responses. You guys are doing awesome. So let me start with some of the sensory overload that's on here. There's probably sirens going on. It's very crowded. There's cars coming this way and that. some folks in other webinars have pointed out to all of the glass and how that's going to be very reflective when the sun is hitting. The signs can be, there's not a ton of signage, but it's also sometimes difficult to see when there's blue on white on blue and it's in smaller font. The folks there who have pointed out that there's multiple entrances, that can also be confusing. Which one do you go in and which one will have an accessible entrance that's not clear? There's not really great signage there. I think one of them, if you look really closely, which is difficult, has a revolving door, which might not be accessible for people who use a wheelchair. Someone pointed out on the crosswalk, there is the yellow with a raised grid so that you can kind of feel when you're hitting the crosswalk, but there's no crosswalk sign, for people to push to stop the traffic. So that's going to be a challenge for people with disabilities. Let me just look at some of the other sensory overload, the noise, tripping hazards. Yes, there's probably many in here. It looks like the sidewalks are pretty well maintained here, but that's often not the case. This is also, someone mentioned weather. We see the winter coats. There's no snow here, but oftentimes snow is very problematic because it's either not cleared or it's piled in places where people actually need to get around. For example, if you have to go way around a snowbank into traffic, it's very dangerous. Next slide, please. Okay, this is one of my favorite ones because this is something new that I encounter all the time. So this is a check-in kiosk. Many facilities have these now in place of a check-in desk with a person. What you see on the screen is 3 check-in kiosks. There's a screen, a touch screen that says welcome. And below that, there's a shelf, maybe to put your papers on, I'm not sure, but there's a shelf sticking out. So have at it. Why don't you put in where you think there might be challenges here? Okay, so some great things in the chat. I love someone said, I use this today. I love it. I went and did a training a few weeks ago and same thing. I had to check in at the check-in kiosk and I was like, oh man. So some things here. First of all, there's no one there to help you, right? So if you have a challenge, there's no one there. People have pointed out the shelf below is actually problematic because if you are a person using a wheelchair and you're trying to reach the screen, it's not height adjustable and that shelf is sticking out. Some others have pointed out that the color contrast on the screen, the white on green, is very poor. It's very difficult to see the screen and the buttons are fairly small. I know I was at a lab yesterday where I had to check in and the button for the check-in was like so small at the bottom that I couldn't even with my glasses see it. And then the person came out and yelled at me, why are you in the waiting room? You didn't like check in the thing. Privacy is also an issue. Oftentimes you have to scan your ID for these, which is problematic also for people with disabilities because you have to be navigating through, your wallet, bringing things up onto the screen. The directions, someone said confusing directions only in English. That's a very good point. I can't see the buttons on the screen. They might say a different language, but often they don't. No messaging where to find assistance. No audio option. Great point. Oftentimes there isn't an audio option for people to be able to access or an option for screen readers. Great. All right, I'm going to go on to the next one. Okay, here's a picture of a hallway in a waiting area outside multiple exam rooms. What you see on the screen is there's many people in this hallway, which is a uniform color. And I'm going to leave it at that for the moment and let others sort of chime in on some of the challenges here. Okay, some really great things in the chat. Um, Let me point first to something that said if you're no masking and also if you're immunocompromised, this is going to be a very difficult situation. I haven't seen that come up in other webinars, and I think it's a great point. We can all see that people have their legs sticking out. It's very narrow. So if you use a wheelchair to get by, you won't be able to get by. It's a very uniform, bright white space. So if you have sensory disabilities, this is going to be quite overwhelming. It's also probably very noisy. The signage on the wall looks to be some kind of clear, like clear writing on a clear sign. Very difficult to see what the sign says. Yeah, definitely not probably compliant here with ADA or HIPAA. Um, there's no signs for direction. I also find that the staff are speaking to the patients in the hallway is probably, difficult for privacy. You can see that there's various, and also just that people are also on their cell phones, as tends to happen in these waiting areas, but that can also be very difficult for people with sensory disabilities. All right, let's go on to the next one. All right, one more within our fixed site. So you've made it all the way into the site, you've made it through the hallway. Now you're in for a diagnostic exam, and this is what you encounter. So here I think we have a CAT scan machine that is with a table in front of it, and it's kind of got blue lighting within the room. So I'll ask you all to quickly post your comments, what you see here. Right, so I see some great comments. I think you're answering each other, which is great that some people are providing answers for some other questions. Staying immobile can be difficult. It's also unclear if this is a height adjustable table. It does not have railings, which can be very disconcerting for people who are worried about falling off of the table. The sensory issues can be prevalent here because of the size of the machine, the noise, the lighting. You do need someone to help with transfers onto the table. But also someone brought up in the chat, for people particularly with cognitive and intellectual disabilities or sensory disabilities, this might be really scary. So you really need to work on preparing people for what they might encounter, maybe having someone accompany them, but really having those discussions early on and maybe doing some initial kind of testing with people before they have to go into the machine, just for getting used to the room. So there's a lot of sort of different issues here, even though it looks like a simple sort of machine in terms of that it's open, it's not, some other machines can be much more claustrophobic than this, but there's still a lot of work that might need to go into it to sensitize people to what they're going to encounter. Someone said in the chat, this is actually quite open and low compared to MRI machines I've seen. Yes, very true. Okay, next slide. So we're going to move on to some mobile sites. So I'm going to show you quickly a patient portal, which is not just mobile sites, but you definitely need more often to use a patient portal to make appointments on a mobile site. So next slide. So I'm not going to ask you guys to pitch in on this one. We'll go to the slide in a second. I just want to point out a few things on this patient portal. And I mocked up another portal and showed you on here. I wanted to point out a few things that you can see where it says welcome to the patient portal, that the color contrast is not great. Also that on the right-hand side where it says enroll now and pay as guest, sometimes people change the font to try and be more noticeable. But if it's not in a standard font or a Calibri font, it can be confusing and difficult to see. Also, one thing that I really learned where it says username and password, when you type in there, username will disappear and it'll make your name. Instead of, some of them have username that's written above the box. That's much easier for people, especially with cognitive disabilities, because it doesn't disappear. You don't have to remember what you were supposed to put in that box. So when you type in the box, username doesn't disappear because it's listed above the box, and it's much more intuitive. So there's just a couple things I wanted to point out on portals. And also, you see at the bottom, at the very bottom right, it says, do not use for emergencies. In case of emergency, please dial 911. Yeah, the enroll now font. Yeah, I have fun with that. It's Broadway font. So the 911, that's kind of an important point, and it's really small and kind of off at the bottom. So you want to make sure that things that are pretty important need to be up at the top. Next slide, please. Okay, so here's a mobile site. This is from, 2020 COVID. We've got some tents going on. There's some testing going on in a parking lot. So I just want to ask people what they see here might be challenging for people with disabilities. And you're welcome to write in the chat for this slide, please. All right, one of the things that people pointed out is navigation. There's not a lot of clear signage here, and the signage that is there is, again, the color contrast is pretty poor with the white on the lighter blue. There's also no one there that's clearly identified to help you. So, someone with a blazer or something that says save point or whatever this is, like, that would navigate you through. You don't know where to go if you need to park, or if you are a person that's using a wheelchair, how are you going to navigate within this space that has cars coming in and out? There are curbs. There's just lots of different kinds of hazards within there. It's kind of different. You can see that there's different types of stones and stuff that are used that have gaps between them. Brick parking lot. Yep, someone wrote that. All right, let's go on to the next one. I just want to say lack of temperature control. I love someone put this in the chat, because when things are outdoor, you have all those kinds of issues. So say you're a person who uses a service animal. That service animal is going to have to walk across that hot parking lot in the summer, which is not going to be good for them if the pavement is over 100 degrees. Same thing if it's slippery or, icy. So this one I'm just going to talk to you guys about. I didn't have good pictures about mobile vans, the inside of them, but I just wanted to point out, because this is becoming really popular to have a mobile van or like a container truck that you put in a parking lot. Oftentimes there's not a ramp to get into the van. And once you get into the van, you can see on this picture here, the doorway is really narrow. So even if you were able to get into the van, you wouldn't be able to turn around if you are a person using a wheelchair. The hallways are often narrow. I had to get IV antibodies during COVID, like in the beginning of the pandemic. And I remember going in, and the transfusion chairs, they had about maybe 10 inches between the chair and the wall, when you got into the van. So trying to even get in and navigate in there was very difficult. Again, on here, you see that the table at the back is not adjustable. And there's kind of benches in the middle of where you would want to be walking. Next slide, please. So this is, I think, our last slide before we go into Q&A. So what I was mentioning before is that in a lot of decentralized trials now, you use some sort of application. So some kind of smart device, or you need to load information into a laptop or an iPhone. So I just wanted to give people an opportunity to note here things that they think may be challenging for people with disabilities. So you all have some great responses. You need fine motor skills to be able to use these kinds of apps. They also often are not accessible for screen readers. The print is very small. It requires a lot of mental processing. You have to remember passwords. You have to remember how to navigate within this app. Oftentimes the help desks are not accessible or in other languages. So to even access the instructions and the help desks, those are not accessible. That you need to be able to pay for the iPhone and the internet service if it's not provided by the trial. You can also see that the person shown here is wearing running sneakers and has two, dexterous limbs, which isn't necessarily the case for all people. So you're showing that this is the only way. It's kind of, in a way, saying that this is what your outcome measure is going to be. Running is running or walking is going to be your outcome measure, and it's going to be done through these applications, which there may be alternatives to that. I just wanted to look quickly at the chat. Digital literacy, great point there. Color contrast, you can see that the color contrast is difficult, especially in the charts with the blue or the green. Can you use voice commands? Really don't know with that app, but it's something really to think about a lot when we can't just give an app out and say, done. There's a lot that needs to go into it in terms of usability testing. So just wanted to end with that on the slides, and thank you for all of your wonderful comments and thoughts that you put into the chat. So thank you very much. So now questions.
Thank you so much, Willyanne. You have given us so much to think about. So I don't know if folks want to raise their hand or kind of come off of mute and just ask Willyanne some questions. We have about 6 minutes remaining in our session, or if you prefer to drop those questions in the chat, can certainly address those as well. Or comments. It doesn't have to be a question. It could just be a comment. Willyanne, I might start with a question of my own, if I could. And I'm looking really for confirmation more than anything. I feel like I remember at one point reading about contrast and the best colors to use for contrast. And my memory is that when possible, using a blue background with yellow lettering is a really effective color combination to provide a really rich contrast for folks who may have visual disabilities. Do you have thoughts on that? Is that an accurate thing to say? Let's start with that.
Well, I confess I'm not an expert on the color palette. We do have links in the toolkit to the different recommendations there. And we are coming out tomorrow on the MRCT website with 6 Accessibility 101 training modules, and one of them is on color contrast.
Perfect.
I will say the color contrast of the Accessibility 101s is the most techy, it's the most challenging, I think, compared to alt text or other things. But generally, just to say, just really, we have in there a link to a color contrast checker that you can do to make sure your color contrast is good for small font and large font, but generally a dark background with light font or vice versa is really good. And I know that you don't want to use like red on green or certain color palettes like that for people who are colorblind, but
sure.
Yeah, generally you can't go wrong with larger font, space between what you have on the screen, and some contrast there.
Yes, but I love that you have put this in a toolkit, because I suspect that many of the folks on this call will want to have that toolkit moving forward when designing research involvement from start to finish throughout the research life cycle. So thank you so much. It looks like Krista, you have your hand raised, so I'll turn to you for your question.
Thank you. That was a wonderful presentation. Thank you. I work my areas individuals with intellectual disability, many of whom are adults and who have are their own legal guardian. and we don't have time to really get into this, is there anything in the toolkit for working with our IRB liaisons to make the language in consent forms more accessible? Like, do you have tips?
Yes. Short answer is yes. We do have, for example, I took an informed consent form language and made it into more plain language. So there's an example of that in the toolkit. We also have a clinical research glossary at the MRCT Center that's been developed to make it easier so you can reference these words. There's some information about specifically unsupported decision making. And I also linked to some other toolkits. There's some great work out of Australia on working with people with cognitive and intellectual disabilities that have some really interesting work about helping people, especially if they have an LAR, the LAR working with them to define their values and their communication priorities and kind of develop these lists so that you have those kind of ready to share with the research team. If that's helpful.
Ask me a little bit more about how I can be convincing. There are certain things that are required.
Mm-hmm.
So I think the template would be useful because I'm sure it has the elements.
Yeah.
I want to be mindful of time, but there is one other question in the chat. And then I did pull up our last slide here for cheer. If you have questions for our initiative, you're certainly welcome to reach out to us. If you have questions for Willyanne, we can kind of funnel those to her. But before we close for the day, I do want to just draw your attention, Willyanne, to the question by Kelly in the chat, which says, how do you work with patients to map your own care space for accessibility? This is a beautiful question, and I think lots of us will want to know the answer to this.
Helping to map your own like facility, kind of what the challenges are there. Is that the question? Or your own office? Or do you mean to map your own sort of journey within that participants are taking with that? Sorry, I'm just not quite clear.
Yeah, so if we're working with a specific health system, and we understand all of the places that the patient will need to go, before having them go through that journey, I think it'd be helpful to bring that patient voice in where some of the accessibility would be. And so I just wanted to see if you had if you've been doing that, and I guess how.
Yeah. I mean, partly we do it with our own working groups. So we have, just like you have in your community, I'm sure with Cheer, you have different working groups, but if they're inclusive of people with disabilities, we work through them. We also work through the hospital through their, I'm not sure if it's under the diversity program, but we have a liaison for disability that helps map that journey, because it really does involve a lot of different aspects across the hospital. You need to know facilities management. You need to be connected to people in facilities management. You need to be connected to people in legal who are help processing that. But the biggest tip that I've heard from people, for example, research teams that are hiring people with disabilities onto their research team, is that you need to start early, like not the first day that they arrive, but once they're hired and they're coming on board, start early to understand what the needs are so that you can get that process moving along. And Mass General Brigham is starting to do something called in their rally system, which is where we list upcoming trials. They're going to be launching a system where they list what are the potential accommodations for that trial. And on the other flip side, people looking for trials can list what accessibility needs they have so that at least you can prepare like early on for that, if that helps a little bit.
I love that. Thank you so much. See, I really just want to, I keep looking at my time because I know folks have back to back to back everything every day. But I would be remiss if I didn't also point out that we would really encourage folks who participated in today's session to complete our evaluation. My colleague Jen dropped the link in the chat for that. That really helps us understand the value of some of these educational sessions that we're offering. And we also really pay attention to a spot on our evaluation where folks have the opportunity to share topics that may they may want to be presented in the future. So not only will we want to, hear your thoughts on Willyanne in particular, but also if there are things that you would like to be addressed in the future, and somehow if Chair can build educational sessions around those topics, we'd be happy to do that. I want to conclude by thanking you once again, Willyanne, for your expertise. There's all kinds of fabulous feedback in the chat about this exceptional session. So thank you again. And we look forward to working with you in the future and hearing more about your work at the Brigham. And thank you all for attending today. Have a great afternoon.